All right. Well, so this might end out having to be two separate YouTubes because I wouldn't know how to stitch these two together. But well, in case, I don't know if my screen just kind of went blank on me, so I have a pretty good idea when we dropped off. But yeah, so these pseudomyxoma peritoneae, they come from appendix or ovarian spilling epithelial cells, mucoid producing epithelial cells, and though they are not cancer, they can spread considerably throughout the peritoneal cavity and cause a lot of problems. Um, if you if you jiggle this belly, or if you push down on it, this stuff will act like jelly or jello. Anyway, okay. Let me just talk through a few of these. Seroma, blood serum, those are usually adjacent to surgery. And lymphoceles, those are also post-surgical. I'm sorry, so seroma is, I said blood serum. A lymphocele filled with lymph, that is post-surgical. Bilioma or bilioma, post-surgical as well, of the removing the gallbladder. Urinoma can be injury or surgery. You could find those at the kidney or at the bladder. And if they're huge, you find them everywhere, as in like urine ascites. Mesenteric cysts they can be lymph in origin. They can be a duplication cyst, which is kind of an inclusion. It's also called an inclusion cyst. Duplication is basically a failure of closure of an organ's membranes, and that leaves a potential space for fluid, and invariably fluid does end up in there. Mesenteric adenopathy, or lymphadenopathy, I showed you a picture of that above the aorta. So lymphadenopathy is the term we talk about or refer to for enlarged lymph nodes. Omental cake, we mentioned the other day, that is metastatic involvement of the omentum. So for some reason, cancer loves to get all over that. Paracentesis, I just showed you an image of, and an abscess drain is going to be the same type of deal there. Okay, let's see, 138. All right, yeah, we're good, good. All right, so I did some drawing earlier because I didn't want to struggle with this while you guys were watching me. Get the right place in my notes. Liver. Supposed to have a homogeneous echotexture. In other words, pretty smooth appearing. Isoechoic or slightly echogenic to right kidney. We'll look at more of that in the future, but basically the parenchyma, the tissue of both, should be about the same echogenicity. If not, then one or two of them have a problem, most likely the liver. And then your book also says isoechoic or slightly less echogenic to the pancreas. I don't like that because the pancreas actually really changes echogenicity from young to old, from thin to heavy. The pancreas has a very wide range of echogenicities, so I don't know how they could even say that. Unless I misread it and we're talking about the spleen, but I don't think so. Weight of the liver in adult is 1/36, the total body weight, whereas in the infant it's 1/18. So babies, and certainly in utero, the liver is much larger per body size. The measurement here, let's draw a measurement. Well, let's see if this is my right lobe, assume it is. No, I'm sorry, I can't even read my own drawing. looks like I need to be on another. Okay. I just drew in the length measurement. So this is the person's the person's right side and the person's left side. Head, feet. Okay. The length is generally, well, I hear so many different things out in the field. But your book says 13 to 15.5. I think it says maybe as high as 17, and that's because, well, like I said, we see all sorts of different sizes out in the field, and what's acceptable is different for different people. I worked at a location where we actually had it 18 centimeters was the maximum before you started calling it hepatomegaly. Hepatomegaly is too big. Two different words, not too big, but too big. And we measure along this line from the dome to the tip. Okay, yeah, I'm not gonna talk about that. It's an intraperitoneal organ covered in double layer of peritoneum, except at the bare spot, and then Glissen's capsule. Okay, so let's write Glissen's capsule is, there's peritoneum all around the liver, but there's also Glissen's capsule, and that's the actual capsule of the liver. That capsule not only goes around the liver, but when certain vessels go in, it's the portal vein and hepatic artery and also the common bile duct. When they go in and throughout the liver, they continue to be surrounded by Glissen's capsule. So it's almost as if, if I'm drawing the capsule around here and then it goes in, and then it continues as vessels break off into smaller and smaller and smaller vessels. Glissen's capsule continues to surround those vessels. And that is why some of our vessels are echogenic walls and some of them are not. So the portal triad, and now that's portal vein, hepatic artery, and bile ducts. The portal triad is surrounded by Glissen's capsule, which is kind of interesting. So I want to talk a little bit more about, I think I can just erase a little more about the relationships of the liver to the other organs that are in the body here, starting with the stomach. So we start off, of course, with the esophagus is coming down through the chest cavity, crosses over the diaphragm, kind of takes a turn and goes into the stomach. This is our stomach, and then there's actually a little muscle right here, but so it goes from stomach, and then we have the first part of the intestines, the duodenum, sometimes also called the duodenum. This over here, actually, when I refer to the C loop, that is what I'm referring to, the C loop of the duodenum. And so the inferior surface, we have stomach, and the stomach would be uptight against the liver here. The C loop of the duodenum is uptight against the liver. Got a couple of other things that are also in here. Well, I was going to do this one first. Here we have the transverse colon, I'm sorry, the right flexure. Right flexure of the colon. So we have ascending colon going up, transverse colon going across, and here's the right flexure here. I'm going to take that away just for a second and add another organ. What I've added here is the pancreas. But I'm not sure why I even added it, because it's not really considered in contact with the liver. Don't know why. I think I just got carried away drawing. So let me get rid of the pancreas for now and get that colon back. And then also the kidney. So, right kidney, I've drawn kind of behind the liver and poking out a little bit down here, and slightly covered by colon, which, by the way, when you're scanning the kidney, we oftentimes have a very difficult time getting the lower pole of the kidney. Well, that's because this guy is filled with air. Or as gas. Anyway. Oh, and you know, JP, I have a new nickname for you, JP. I was doing a little. I don't know how this came up, but John Paul Jones. And I was thinking about what I used to read to my daughter, Skippy John Jones. So I think your new nickname is going to be Skippy John. Maybe just Skippy for short.
Take it.
Liver relationships, liver anatomy. You want to save changes? No. Okay. All right. Go ahead. Let's take a break. I know this was a little painful, but unfortunately, there are things I just have to go through. I've got this one, and I've got something else that I'm actually pretty excited about. So, second part is going to be a little more dynamic and fun and all of that. So, I will see you in about. Let's see. Well, it's 1:50. 2:05. Let's do 15-minute break here. So 5 minutes after 2, I'll see you guys again. area and all right. So in your book, welcome back, guys. Well, in your book, it goes into ligaments, but I thought that was a little bit confusing. So we're gonna skip ligaments and go into the lobes first. And by the way, these ligaments, these so-called ligaments, are really just folds of peritoneum. So you have the parietal peritoneum coming in around the outside of the body, and then there's now we have a ligament holding the liver up. Well, it's peritoneum, or the liver to the stomach, peritoneum again. Although they call it ligaments because it's specialized peritoneum, but it is all continuous. All right, so when we look anatomically at a liver, we see pretty clearly, and let's add a drawing layer here. Okay. We see pretty clearly, well, sure, that's the right and that's the left, and the right's bigger than the left, and that's what the book says too, so that's okay. And that's as far, that's perfect. And so anatomically speaking, that is correct. And we have some external landmarks that give us that information. This little circle right here is kind of cool. That used to be your umbilical vein. It is now just considered, I want to say the round ligament. That just the circle there, and so basically this circle, and it does go up. It continues up into the liver, but it's hidden, and it's hidden inside a double fold of peritoneum. The ligamentum, that's a G there, ligamentum teres. Ligamentum teres, double fold of peritoneum. This actually, both the ligamentum teres and the round ligament actually go all the way back to the belly button, or umbilicus. Oof. Umbilicus goes back to the belly button. Okay, so ligamentum teres, round ligament. And we see this inside the liver as an echogenic focus within the liver, and it's something we're supposed to see. I did have a really good doctor, very, very good doctor, but she for some reason completely forgot what this is supposed to look like, what it was, and she calls me up and says, "Hey, Kurt, why did you not mention?" And it's usually somewhat triangular shaped. "Why did you not mention that tumor in the middle of the left lobe of the liver?" I said, "Doctor, there's no tumor there." And I went back and looked, and I said, and she says, "Here, right here." And still struggle to understand that one, because this is so obvious to me. It should have been obvious to her as well that it was actually a normal structure. It's the ligamentum teres. So the ligamentum teres, yeah, okay, so I do talk about this a little bit. Splits up here. As it splits, there's an area we've mentioned this before. The bare area is not is not seen, or is not covered with peritoneum. So peritoneum's coming around, it comes around the liver, folds up, around the liver, folds up. This is the only, well, I was going to say the only spot not covered with peritoneum. That's not entirely true. And then on either side, this side as well, we'll call this the left cardinal ligament. And of course, this is, I'm just going to do a right cardinal ligament, RCL. The darker blue represents the diaphragm, by the way. Okay, these cardinal ligaments, they're suspending the liver up here. They are continuous with the ligamentum teres all the way down to the belly button. They are, of course, continuous with both the parietal and visceral peritoneum. Okay, poking out down here, I'll just mention, is the gallbladder. And now I want to pay a little more attention to my next image over here, which, as you can imagine, I have more things going on. I'm going to magically draw in, actually, let's do the portal veins. No. We're going to do the hepatic veins first. Boom. Hepatic veins. Now, these are the three main veins that drain the liver. This is the left hepatic vein. Naturally, this would be the right hepatic vein, and this one, the middle hepatic vein. Now, back over on this picture, we said, well, obviously, when you look at this, that's the right and that's the left. Oh, by the way, this ligamentum teres, this division happens to be about in the middle of the body as well. So all the more reason to call that right and that left. But the reality is that the liver isn't one solid mass. It has, let's just see. Okay. It has fissures. In other words, there are three large fissures going through the liver. And guess what? I probably should have drawn that one a little bit more like that. There's fissure 1. Here's another fissure, and then another fissure. So these guys have names, of course. Right lobar fissure. So it's interesting. I'm able to write on this stupid thing now, and I realize it actually has to do electronically with the canvas size. If I had the canvas too large, the handling is all wrong. So thank God I figured that out, because now I could actually read my own writing. And probably most importantly, the middle lobar fissure. You might notice that I've drawn these lines right through the right middle and left hepatic veins. Hepatic veins run, I gotta say this right, intersegmentally and interlobar. So they are traveling between the lobes of the liver and those segments of the liver. We have another structure that comes in, it's the portal vein. They're going to run very differently. But what this ends up being, since we have a middle lobar fissure, that is going to be the true difference between right and left. So everything to this side is right. Everything to this side from over here, well, let's do a little left here, and this is left as well. And this is right, or this is right as well. On this side, we have a left lateral segment and a left medial segment. We have a right it's Old English post, right posterior segment and right anterior segment. So those are the major segments so far. Where did I? Okay, good. Let me just look at my notes here, guys. Segmental division, fissures and portals, main lobar fissure. Oh, right. And notice, by the way, that this main lobar fissure goes through the gallbladder. Gallbladder resides in, I'm going to say in/under main lobar fissure. Gallbladder resides in or under the main lobar fissure. The main hepatic vein is inside of the main lobar fissure. Right intersegmental fissure divides right lobe and anterior, medial lateral, also umbilical. Oh, right, that's okay. Okay. So that's basically one way, or the first half of how anatomically speaking, technically speaking, or really surgically speaking, oh, my handwriting is beautiful now. I love it. Surgically speaking, this is important because a doctor can remove, well, that segment. Or they could say, let's remove the entire right lobe or the entire left lobe. We could remove these, but so you remove them by segments. You don't just simply cut across in any which way. Now let me add another layer. This might get a little ugly. Yeah, it's not too bad. I'll erase a couple of things. Okay. Actually, let's go ahead and so now we have our portal vein coming in. So yes, the liver has two venous systems, pretty crazy, but it is. We have the main portal vein, right and left. The right portal vein divides, oh, I do 2, 3, 4, 5, 6, 7, 8. Okay. The right portal vein travels in the middle of segments. So the lobar, or I'm sorry, the hepatic veins travel in between segments, in between the fissures. And a fissure basically is what it sounds like. It's like a separation between two lobes. These guys travel in between. These guys travel right through the middle of segments. And so they also, let's do my, they also will further subdivide. And in fact, I'm going to go ahead. I wasn't going to do this because there's a way of discussing the liver anatomy. Quenos got it spelled out. It's a French word, a French name. C-O-U. Quenos. Anatomy or Quenos taxonomy. I have to skip we're going to number these. I have to skip number 1, unfortunately, and the reason I have to do that is because number 1 is the caudate lobe. Actually, I'll just do this. Number 1, caudate, not seen. Number 1, caudate is not seen. And that sits behind the liver in this area. But if we come further out, we have segment number 2, number 3. Number 4 is pretty large, so we have 4A, 4B. Oh, I needed one more. And then from there we go number 5, number 6, 7, 5 goes up to, and number 8. Yeah, I could have drawn this slightly better, but you get the basic idea. And I have more images that we'll go over, which will be much better. But now doctors are actually able to say, and well, hopefully we will be able to say once we get in the lab and start practicing looking at the different lobes and sections, is to say, gosh, doctor, I saw a tumor in the number 2 section of the liver, or number 4 or number 8 section of the liver. I was able to find a tumor. Most people don't, most sonographers don't get into this. Many radiologists don't, but the ones who do, they're going to expect you to know that. So we are definitely going to practice this. Let me back up here. You know what, I'll be honest with you guys, I did not write down the specific, because I don't want to say it wrong, on how the main portal vein divides. I've drawn it really essentially correctly, and I have these numbers are correct, but I want to get my wording correct, so I'm not even going to say it right now. I'm going to write a note for myself, and we'll cover that again on Monday. We'll review it on Monday. Anyhow. Okay. Then I just have one more thing to show you. And it's actually pretty cool. Got to play with another program here. Oh, God, I hope this all works. Oops. Not what I don't know what I just undid. Okay. Yeah, looks like it's working. Okay. So I've drawn a really basic liver here. Could pull that liver backwards a bit and show you some of the vasculature. So we have the IVC is running obviously up and down, cephalad, caudad, or caudad to cephalad, as it were. We have the right hepatic vein, right hepatic vein, middle hepatic vein, and left hepatic vein. Then we have our portal vein, and we have a lot to talk about with the portal, so don't feel like if you're feeling a little confused, don't worry about that. We have the portal vein coming in. These two are not really in the same plane, because like I said, these guys travel through fissures, through natural fissures in the liver, and these guys run right through in the middle of segments. Now, I did want to show something about the way we look at this. Actually, I'll just leave it back here. Well, it's kind of, let me just see how everything comes in. Oh, I know what I want to say right now. Every student asks me where the porta hepatis is, or in fact, let me pull this back up. The porta hepatis, let's do a nice color here. The porta hepatis is the doorway to the liver. Students, when they're in lab, expect to find something. They expect to see a object, a organ, something in their view, and there really is nothing. It's the doorway. It's a lack of something. But if you're going to look for the porta hepatis, we find where the vessels, where specifically the main portal vein is going into the liver. That's the porta hepatis. And this area here is the porta hepatis on this picture. Now, here comes our transducer. I made that too, I'm quite proud. If we're perfectly transverse on the body, right in the epigastrium, there's our transducer. Looks like it's looking up, and that's fine. But if we want to see certain image, and that's great for looking at the left lobe of the liver. This configuration of the transducer is not so good for looking over here on the edge of the liver. So we're transverse, but we're also a little bit oblique. And the rib cage is coming down here. So we are right under the rib cage in the epigastrium, in the middle of the belly up high. Now, let's pull this back. Taking a second look. You can see that the transducer is looking up at not only the liver, but the 3 hepatic veins. If you're lucky, you have all 3. Sometimes you get 2. We're looking up at it. If you think about it, the base where all 3 of these meet is far away from the transducer, and the let's move this guy a little farther away, right there. And the arms, this distal part of the arms, especially in the middle here, is closer to the transducer. Our perspective when it comes to ultrasound looks nothing like this. It does, in fact, look let me just pull it over here because it can get a little confusing with all this other stuff. Our perspective, let's see, we're looking at it. Wait a minute. Yeah. I confused myself there for a second. When we see, imagine there's a whole screen behind us here. The ultrasound screen is here. We see that this configuration, if we see all 3, sometimes we do, this is what we see: right, middle, and left. But it's upside down. Our transducer on our screen is up. Our transducer is essentially up there, right? But that makes sense if you think about it. The face of the transducer, I said earlier, was closer to the arms. The base where all 3 of these converge, and this is converges at the IVC, is further away. And so when we see these hepatic veins, we see them not as they are, but as we see them. We see them upside down. And I had to turn it a little bit because, well, when we had this guy down here, he wasn't straight, he was turned. Let's see what he's turned at. Hello. Well, how is it that? Okay, never mind. I thought I was going to get good degrees out of it. Since this guy is turned a little bit oblique, this guy's a little bit oblique. So we come back, roll it back down, walk it back over here where it's supposed to be, and then bury it inside the liver like it's supposed to be, right about there. Now that demonstration is actually better served if we're actually scanning, but let me come back to find that one image. Do you want to save changes? I don't think so. Oh crap, there it is, yep. Actually, Actually, no, let's do this. Okay. So our transducer is essentially up here looking down. Well, not really. I mean, that's always like that on our screen. Obviously, our transducer is always up top on our screen. But the way we're actually holding the transducer is low and looking, well, we're holding a transducer looking up into the patient's right. And so that's why we essentially, when we see this configuration, that's the middle hepatic vein here. This is the right. When we see this configuration, it's essentially upside down. Let's see if I can remember my, let's see, 5, 6, 7, 8. So I remember when I was doing Queneau's anatomy before, it was like 5, 6, 7, 8. 8 being on top over 5, 7 being over 6. Well, 7, 8. Let's see, 6 is more down here, and that's 5. So it's our perspective is upside down, therefore Queneau's anatomy as well is upside down. 237. Okay. Well, hopefully I was kind of proud of this guy. Hopefully that helps a little bit with understanding our anatomy.
It's not bad considering we can't scan.
Right, and that's exactly what I'm trying to get here. You know what? Let me just quickly look at my notes, make sure. Caudate lobe. Let me give. I'm gonna give this guy caudate lobe. Let's give you a caudate lobe. It's actually a little painful. Let's see if I can do this relatively quickly. Brown. No. Yeah, totally wrong. Over a bit. Oh, it even buries in. Oh, I love it. I love it. All right. There we have a caudate lobe. Let's group that. So the caudate lobe is, by the way, more or less, well, it is a separate lobe. That's why they call it a caudate lobe. But, you know, we have our, and this is the number one, by the way. When we're doing that Queneau's anatomy, this is number one. I couldn't draw it before because it is behind the liver. Let's see if I've aimed it. Oh, yeah. And it sits above and a little bit inside or medial to the IVC. So let's see if I got that correct. I got pretty close. Select all. Oh, that is total luck, but that is beautiful. That's exactly, looking from the backside, this is exactly what the caudate lobe looks like. A little bit above the IVC, but more medial to it. And of course, we have to think about it this way. Let's back this through. Oh, I got a hold of everything here. Yeah. So the caudate lobe has actually a very small branch of the hepatic artery that runs to it. It also has its own hepatic vein as well, but both of those are quite small, sometimes very difficult to see. Interesting thing about the caudate lobe is that since it's its own lobe, it sometimes avoids the injury that the rest of the liver can have. So you could have an entire liver sick with cirrhosis, and the caudate lobe is spared. And when that happens, the caudate lobe grows in size in order, and it's called compensatory hypertrophy. It grows in size in order to take care of the body because the rest of the liver is now dying. But okay, quick look at my notes. Caudate lobe posterior has its own blood supply. Now talk about the ligaments. Okay, well, we'll talk about ligaments next time, and I'll also bring up better images of Queneau's anatomy, and I'll explain a little bit better how the portal vein divides in Queneau's anatomy. Oh gosh, I have all sorts of good notes. Yeah, this is the part I like, just anatomy and talking about how all the things go together. All right, let's shut that. You want to save your work? Sure. All right. So I see. I think I've got most of your homeworks in. That's great, and I will maybe on, if not today, definitely on Saturday. I'll post some more things for us to look at for to kind of get credit for doing lab. But once again, it'll just be videos. And I do strongly suggest that you look at those videos. They are quite, I thought, quite good. But all right, I think that is all for today. Yeah, it is way cool. So it's Friday, isn't it? So I like working from home, but there are parts I don't like. And actually, it's like I love doing this online, but it's also really stressful because, well, basically because we're winging it, and I'm doing the best everyone's doing the best we can, but it is a little bit of an unexpected departure from the normal for us, but I think we're good. But yeah, guys, let's see. I don't know how to get I can't get my meeting controls back up.
Bye.
All right, bye-bye.
Yeah, I got a question about the homework if you got time.
Sure. Oh, do I want to end? Yeah, I can end meeting. What you got there?
In the chapter 3, under the image evaluation part, number 4, the image is not even in the book at all.
Oh, let's see. I'm sorry, what page are we on again?
In the workbook, it'll be page 26, number 4.
Type of ascites is seen in this image. Yeah. What pathologies can result in this type of ascites? And what structures? Yeah. Well, you wouldn't really know what structures that is if you don't have a picture in the book. Well, the ascites is it's totally clear. So should be exudate, right?
No, that would be transudate.
No, I'm sorry. Yeah, transudate. Transudate. So it's a transudate ascites, probably some kind of venous hypertension, congestive heart failure, portal hypertension. I think the book gives a couple of other examples. And as far as what they're pointing to, that's actually intestines. Looks like large intestines. You can tell large intestines by the so-called hastra, which, if you can see my little picture still, I don't know, the hastra are like kind of like these little folds along the intestinal wall.
I can see that because, like, for some reason, I thought, like, I was thinking, I was like, man, is it just like a really zoomed up kidney?
Yeah, I
Or
could.
like, I know they were talking about that you have like those kind of pyramid shaped things inside of the.
Mm.
Inside
Oh
of the
yeah,
kidney.
yeah,
But
yeah. That
then
kind
like
of.
but not even gonna lie to you, man. Like I went to the internet for that one because I was like, I have no clue what that is. So I think I put like bowel or something in there.
Oh yeah, yeah.
Like the first two parts of the question I'm okay with, but I was like, man, I have no clue what that structure is.
Yeah. Let's see what potential space and loculated ascites on that one. Okay.
Which one has
Cool.
inoculated ascites?
Well, I would call number 5 a loculated ascites, but it's loculated for so loculations like that cobweb-like look. Doctors call that on page 27, number 5 there. Doctors call that loculated. It's just a term they use.
Loculated.
Yeah.
I think I put whatchamacallit again. I can't remember if I put the transudative for 5 or for number 1 under the case study.
Let's see.
Because like wouldn't it have both as far as the case, because like one's above the diaphragm and one's below. So like one would be pleural effusion and the other one would be ascites, the transural.
Yeah, but those are both 5, 4, and number 1. And those are all ascites. 1 and 4. Exudate, and then number 5 is some kind. 5. What does cause that? That's more of a.
Is that like a matrix of some form that's going through there?
What of? Oh, did you say a matrix?
Yeah, because I was trying to remember. I know that you can have like almost like, I call it dust particles and stuff like that and stuff like that. But then it says that there's also something else that could be in there that would make it. Oh, I'm in chapter 5. That's why I can't see.
Yeah, so loculations you can get with a bleed, although this does not look like a bleed at all. Because with a bleed,
that's what I was thinking.
Yeah, because
it's matrix, but it's material.
Well, there's loculated ascites. Complex loculated ascites demonstrates multiple septal apparent sequestered pockets of fluid. Of course, it doesn't tell you what it is. Loculated peritoneum, hematoma. I wouldn't say pseudomyxoma peritoneum, seroma, no, lymphoma, myeloma. Yeah, I don't know what kind of ascites or what would cause that particular look, but it's definitely, you call it loculated, but if it could be blood can first start to coagulate and then starts to break down, and it could leave loculations behind. But like I said, though, I don't think that's what we're looking at there.
Yeah. So that's all abscess, and those things are inside of the abscess. So that's not like anything structural for that part of the body, right?
No. Well, so the only other thing that I was thinking this could represent is some adhesions within the body, and so adhesions can abscesses can cause scar tissue. Scar tissue and adhesions are really the same thing.
Mm-hmm.
And so there could be like a webbing of tissue in the body from previous infections. So now you have ascites with evidence of a previous infection. That's also a possibility for that loculated ascites. I have to look. You know what? I've seen this image on the internet too. I'll look up and see what they found on that.
Yeah, and then that's strange. Like while we're at it, that like you have a whole section right here that's dedicated to describing ascites, and it doesn't say anything about loculated ascites. Is that because it would fall under like these are just like two broad categories of ascites, and then you have like different kinds of ascites that can fall under each one, like loculated?
Well, loculated is it's a term. Can you see my screen?
Yeah.
Yeah, like tuberculosis, peritonitis. Wow. Oh my God. So that's tuberculosis, peritonitis as well. This woman is in a lot of pain because, first of all, this is ascites, but God, those are all basically adhesions. Ugh.
Does it say uterus? That it's her uterus?
Like here's, yeah, that was the uterus there in the middle of that image. There's ascites with some connections in between. They're calling those adhesions. Let's see, this is a good one. What happened? Radiology assistant's pretty good. Let's see. This is a good website, by the way. Radiology assistant. It's a little. Oh, so now here's a CT image with loculated ascites in there. Mucinous carcinoma. Okay. Uncommon pseudomonas. Okay. Where was that ultrasound image? Peritoneal inclusion cyst. Multilocular peritoneal inclusion cysts are benign cystic mesothelioma, uncommon binary. It occurs in peritoneal scarring. So yeah, looks like the number one cause for that kind of appearance is going to be adhesions.
Mm-hmm.
Well, we're getting close. That looks like the same. So there's a kidney here, which looks like a kidney cyst on it. Of course, this one's not going to give us an answer. It's going to make us work for it. And presents with hypertension. Well, she's on. She's on anticoagulant for a Budd-Chiari syndrome and presents with hypotension and right lower quadrant pain. So if she has hypotension, she's on anticoagulation drugs. I think they're leading us down the path that this is a bleed, but like I said, this isn't like a fresh bleed. This is a bleed that started to resolve and then perhaps started to bleed again. Image.
So when it starts doing that that loculation, that's blood that's been there for a while, and it's starting to move into a different phase, like the one that comes after organizing, or
See.
is that organizing?
So image what? Yeah, well, it's starting to organize. Let's see, right upper quadrant, fast exam. It's I forgot what the FAST stands for, but basically this is an ER procedure. You just quickly look through the abdomen, just take a bunch of pictures and run. There's a complex cystic structure with internal loculations. There are some ascites and an incompletely visualized cystic structure involving the upper pole of the right kidney. Yeah, there's that. Oh, are you still? Can you hear me all right? You might not be able to hear me, so there's fine dependent layering.